Oh, I'm Robert McMullen, MD. I'm a psychiatrist. I went to Georgetown Medical School and I went to Columbia Presbyterian for psychiatry. I've been specializing in psychopharmacology for over 30 years. In the last about 9 years, I've been doing also TMS, transcranial magnetic stimulation. Now, what I want to talk to you about today is about sleep problems. And this is such a complicated set of problems that maybe sometime I'll get things much more organized and detailed and do this again. But I'm going to cover some general things. Now, first, how are the sleep problems connected with psychiatric problems? There are quite a few different ways, but one important one is that after people are in remission from their depression, if they still have a sleep problem, they still have some insomnia, they still have a tendency to oversleep too much, then they can be, that can actually be some symptoms that are called residual from the depression. And if you have residual symptoms of depression, you've got a much higher chance you're going to relapse within the next year or so. And those symptoms might just be a little low self-esteem, a little lower energy, not enjoying things quite as much as you could, just having a little less motivation and excitement about things, and also having a tendency to have insomnia, either difficulty falling asleep or waking up during the night, or a tendency to oversleep and sleep 10 hours or 12 hours if given the chance. And the sleep problem should be treated aggressively. Now, there's another problem we have with the sleep, is that sleep and depression go together, and even when the other one doesn't exist. So even if your depression goes away completely and you're not depressed at all, and you're not on medicine, or you're just on a little bit of medicine, the sleep problem may persist, and it's as if it's really two different problems. It's just that they coexist, like blue eyes and blonde hair. There was a study once in some internist office, and they found everybody in the office who was having a significant problem with sleep and insomnia. People that had insomnia but were not depressed. And then they go back a few years later, and half of them are in depression. So it's a predictor that you'll go into depression even if you're not currently depressed. So there are problems that just co-occur. Now, another problem is that if you sleep too much, it causes more depression. And people with atypical depressions, we call atypical, they're actually sort of typical because 1/3 of those of us with depression have the atypical symptoms, and those atypical symptoms are oversleeping, overeating, craving carbohydrates, and being somewhat rejection sensitive. So if a friend of us gets a little mad at us about some small thing, we get devastated. Or if we have a romantic breakup, we go to bed for 2 weeks and sleep. We really go into a depression over perceived rejections. And with those people, since the symptom of the depression is oversleeping, and oversleeping causes depression, then it's a vicious cycle. And the best way to treat them is if you can get them out of bed in the morning and cut them down to 8 hours of sleep, or better yet, cut them down to even less, and go to sleep earlier and get up really early. And that helps bring you out of these depressions. In fact, it's taken to such an extreme that if you give someone like this a night where they can't sleep at all, and then the next evening you allow them to go to sleep whatever time they want, and then a second night do the same thing, keep them up the whole night. So one night, then they can sleep the next night, and then that often brings people out of depression in a day. But this is difficult to maintain, and one way of maintaining it is, after this has been done a couple nights in a row, is to then induce the patient to go to sleep earlier, like 9 or 10 every night, and get up at 6 a.m. and move the whole sleep cycle earlier. In bipolar disorder, sleep also often plays a big part, and lack of sleep can put you into a high. Now, if someone is not getting enough sleep and they're bipolar and they're a little activated and they're a little anxious and worried and they're only sleeping 5 or 6 hours a night, it's rather difficult to figure out whether this lack of sleep is causing them to go into a little high, or whether they're getting a bit high and the high is causing them not to need much sleep. It doesn't really matter. They just have to get more sleep. They either by willpower or by taking some medication that'll really sedate them and put them out for the night, and so that they get at least 8 hours sleep. And all of us need 8 hours sleep to be really efficient the next day. About 15 years ago, I went to a conference, and the sleep specialist there said we all need 7.5 to 8 hours, and we think so much more clearly that it's well worth the extra time to put in to get that sleep. We think we're getting more done by working all the time and only sleeping 5 or 6 hours, but we're not doing very efficient work, and they've measured this. And so since then, I've made it a big point that I always sleep 8 hours, and I'm much better off for it. One of the commonest problems with sleep is the sleep phase delay. And this is because our internal clock for going to bed and getting up is longer than 24 hours. So if you put somebody in a room with no lights and no clocks, and they can do whatever they want, every night they'll go to sleep a half an hour later or so. And a couple of weeks later, they're going to sleep at noon, sleeping 8 hours, and they feel fine. And this constant tension of our wanting to go to sleep a little later and have a long, that evolutionary wise, it's in order to trigger the brain to know what the season is. So when the light gets earlier and earlier, it triggers the birds to know it's time to fly north. And so that's why there's this difference in the timing. But it makes it difficult for us that on the weekends we'll sleep in later, so then it's particularly hard to get up on Monday. And if somebody has a shift work problem where they have to work different shifts, it can be highly destabilizing to their brain and to their mood disorder, and you just cannot adjust that easily to a sleep cycle where you're working at night and awake during the day. In fact, almost nobody really adjusts, and these people live a few years less. So it's really not a safe thing to do, actually. Now, students really get into trouble with this sleep phase delay, especially in college. If some days they don't have to go to class till 11 or 12, and then they sleep in a few days, then their internal cycle is to go to sleep at 2 a.m. and get up at 10. And then to get up earlier to go to classes can be just torture, but not enough to move their clock earlier. And in those cases, they have to make a major effort to force themselves up in the morning, maybe take a little pill to go to bed at night. And it also helps to take the sleep hormone. There's this hormone called melatonin that we make in the pineal gland. And it's a very ancient hormone, and even very primitive species use it. And this hormone is very high at night, and it's very low during the day. And if you take it at, say, 11 o'clock, and maybe 20% of people, it helps them sleep a little, makes them a little drowsy. And I just use maybe a 3 to 5 milligram pill and bite off a chip, a quarter of it, and then let it dissolve in your mouth. Chew it and let it, because that way it goes right into your skin and into your bloodstream, and it hits you quicker. If you swallow it, a lot of it gets digested. And these doses that they sell nowadays, 5 milligrams and 10 milligrams, are really overkill. They're really very big doses. If you just chew a half a milligram pill, you'll get plenty of effect. Now, even if it doesn't help you sleep right away, the melatonin after you're taking it a few days or a few weeks helps you regularize your sleep schedule and your internal clock to a regular time of going to bed. Another way of dealing with a delayed sleep phase or insomnia in general, or especially insomnia that's associated with somebody being a little hyper, a little manicky, is to use blue blocking glasses. And these are amber colored glasses that you can get easily on the internet for $5 or $10. They were originally used by welders. Same color glass, I think, that welders use. And it turns out that our brain only knows that it's daylight because of blue light. And some people think this is an evolutionary thing, that primitive animals arose in the ocean, and when they looked up, the light coming down tended to be bluish. But it's only blue light that we recognize as light. So if you put these amber glasses on at 6 o'clock, then 6 p.m., then for the next few hours, your brain thinks it's in complete darkness. You can go around and do things, watch a movie, get on the computer. Try not to do anything too exciting because you want to be calmed down so you can go to sleep. And that makes it a lot easier to fall asleep, and it helps move your internal clock earlier. This was used as a treatment years ago for people who were manic, was to keep them in complete darkness for 14 hours. And it worked. It helped stop their mania, but it's pretty boring to just sit in the dark for 14 hours. With this blue light, you can do the same thing, but they can do things because they can see. They just have to wear these glasses so the blue light doesn't come through. And that's quite an advance. And people are sometimes quite surprised that they can go to sleep at 10 o'clock or 11 o'clock and get up an hour or two earlier than they ever have gotten up before, because it's moved their cycle earlier. There are other problems with sleep. One thing that is called primary insomnia is people that have really terrible problems with sleep, and they feel like they're lying in bed for hours and they're not asleep. Now, actually, if you look at them, they do seem to be asleep. But in a way, they're right. If you hook them up to an EEG, the EEG shows the characteristic slow waves of sleep. But actually, they have some background waves that are found in a wakefulness. So they really are in an abnormal sleep. It's as if they're half awake and they feel very unsatisfied. Now, if these people never take a nap, If they can't, if that's really their problem, they can't sleep, and they also can't take a nap during the day, then that's really primary insomnia. And that is sometimes a little difficult to treat, and sometimes you need a behavioral therapist who specializes in sleep to do it, and you actually may have to constrict their sleep and force them up earlier and force their sleep to be pushed into an 8-hour period rather than a 12-hour period. That's one way of dealing with that. Now then there's sleep apnea, and people who snore, maybe only 50% of them have sleep apnea. But if people snore a lot, especially if they're men and their neck is 18 inches or larger, they're very likely to have sleep apnea. And with women, it's something like 16.5 inches. It's a very high rate of sleep apnea. You can also tell a little bit by opening their mouth, and if you can't see their adenoids, all you see is the tongue and the palate. You can't see back very far. That's another good chance that they have sleep apnea. And then those people go into a sleep lab, and it turns out that dozens of times at night their throat it closes off from the negative pressure of breathing in. It's like a balloon where if you do negative pressure on it, it flattens out. And this happens in our throat. And the only way to breathe then is you have to half wake up so that you can take voluntary control of these muscles to open up and breathe. So they're not getting any good sleep all night, and you need 1 hour or so of really deep sleep, stage 4 sleep. That's absolutely essential to life, is to have that amount of sleep. And you will get it, but if you have the sleep apnea, it's so disturbed, you can only get it for a few minutes, and then you're back almost awake again to breathe, and it's really very disruptive, and people are left very tired the next day and exhausted and sometimes more depressed. Now the medicines that you can use for sleep, it's really good to try to find some way of reaching a point where you can sleep without having to use medicines. And this is not always possible. Sometimes you just have an insomnia of some sort that's driving this, and it's just you're just not going to be able to go without the sleeping pill. I had a patient once who was in her 30s, and she was complaining bitterly about the fact that she needed a sleeping pill. And I just felt, well, what difference? You know, if you needed to sleep, you just needed to sleep. And she was very upset about it and felt she was dependent on it and everything else. And after some years went by, we were able to stop her Prozac. She'd had chronic depression, and for some reason we were able to stop it. And immediately she could sleep fine. So it turns out it was the Prozac causing her the chronic insomnia. And I think in other people, it's just their own brain chemistry keeps them doing it. There's also something called Restless Leg Syndrome. And this is usually not that hard to diagnose. Usually the person has a restless sleep. They don't sleep well. They're tired all the time. And they've got the sheets and the blankets are all pushed all around. Or if they have somebody who sleeps in the bed with them or checks in on them, they push that person around. Their legs are moving. And sometimes they feel it early in the evening. Their legs are restless and a little achy, and they have to get up. But sometimes they don't remember it at all, and it just happens when they're asleep. I had one lady who was 40 and had chronic depression, and whatever we put her on, it worked perfect. You know, her mood was perfect. But she was still tired all the time. And it was really confusing, but she was just like as if she had very terrible sleep, except she slept a normal amount of time, and she wasn't at all overweight. She didn't snore, and her husband said, you know, her legs didn't move around at night. There wasn't anything that we could find. But finally I sent her to a sleep specialist, and it turned out she had Restless Leg Syndrome. The only thing was, when she had it, her legs hardly moved, but they had EEG-like leads on her legs, and they could see all the muscle twitches going on. And when those muscle twitches happened in the legs, then it would cause her to wake up, to be partly awake. And she began taking one of these, there's some Parkinsonian medicines that are dopamine agonist, and you can just take them at night, and they really take care of this problem. One of the things that causes restless leg syndrome sometimes is low iron, which happens frequently in women because they lose blood every month, and iron is what makes blood red. You need iron in your blood. Men, when the red blood cells get old, then men just reuse it. But women are losing it every month, so they often develop a low iron level, and the low iron level can sometimes cause this restless leg syndrome. Now, back to the medication strategies. I mentioned that melatonin can sometimes help sleep, and it can sometimes only help sleep by helping to regulate your circadian rhythm. Other medications that work are Ambien, which is zolpidem. That's the most commonly prescribed one, 10 milligrams. Women really only need 5 milligrams, and sometimes they don't know that because they never tried it. But it's easily breakable, and they should try 5 milligrams, break it in half. Since it's relatively short acting, usually in the morning you're not particularly drowsy after it. One of the major problems with it is some people on this type of medicine will wake up in the night and then do things and then not remember them. Like go down and make a sandwich and say hello to a guest in the house and go back up and seem perfectly normal but have no memory of what they did. They don't do anything abnormal usually, but it's just upsetting to people. Sonata is very related to it. It's Zolpidem. Ambien is zolpidem. This is Zolpidem, and it is much shorter acting, so it's really out of your system in 4 hours. And you can easily take 2 of the 10 milligram pills, and you're not likely to be drowsy the next day. And you could even take one at 2 a.m. or 3 a.m., and you're probably going to be okay to get up in the morning. A non-medication treatment is tryptophan, an amino acid that you can get over the counter. An amino acid that's found in muscle and meat. And you get 500 milligram pills and take 3. And it frequently makes you mildly drowsy and does not leave you groggy the next day. Another one is an old antidepressant called Doxepin, Doxepine. It's being sold as a sleeping medicine now in a 6 milligram pill, I believe, Silenor, Silenor. But you can just get a 10 milligram pill that's generic, and that gives you a reasonable sleep sometimes. We're often using trazodone, an old antidepressant, and Seroquel, an atypical antipsychotic for sleep. But I'm not as enthused about them because we don't know how normal the sleep is. And I think it's a mistake to use Seroquel for sleep because even though it's the safest of the antipsychotics, it could cause a movement disorder like tardive dyskinesia. It could have some odd side effects, and it'd be preferable to use something more simple. Another good medicine to use is clonidine, C-L-O-N-I-D-I-N-E, which is an old blood pressure medicine, and it's also used for attention deficit disorder. And you can take the smallest dose they make of it, 0.1 milligram, and take 1 or 2 at night. If you go higher to 3 or 4, you have to be careful it's not making you dizzy or something. But that's a nice thing because it reduces anxiety, it doesn't leave you sedated the next day, and it's a great idea for somebody who has attention deficit disorder because it may help that as well. Also, just a lot of exercise. If you exercise a lot, you're not going to have that much difficulty sleeping. You know, if you've ever gone and helped out on a farm, or you ever go on skiing for a few days and you ski all day long, you don't have any trouble sleeping that night. You know, and the way our ancestors lived, you know, my grandparents, you know, had a small plot of land out back where they grew all their vegetables and raised chickens, and they were just constantly working. The washing machines didn't come in until the 1930s, so that means you had to wash your clothes by hand, then go hang them up, then bring them in, and then the end of the season you'd be canning fruit and vegetables for the winter, and bringing in water from the pump, bringing in ice to put in the ice box. That's why they, up in Michigan where I'm from, they still call it refrigerator and ice box. And you were just working all day long, even if you weren't a full-time farmer. And things have changed, but when you were doing these things all day long, you'd be tired at the end of the day. And people weren't crying for sleeping pills so much back then. And if we put a lot more time into exercising, you know, walk wherever you have to walk. If you're in an office building, try to go up and down the stairs rather than use the elevators. Everything you can do to exercise helps everything. You know, sleep, you get anything you can mention. Heart attacks are less, even cancer is less with people who exercise more. So that's a bit of a summary of the different sleep disorders and their connection with mood disorders. And there'll be new things coming out, and I will try to give another talk on this that's more detailed about some of these agents that we can use. Thank you very much.